طيب بسم الله الرحمن الرحيم. We're going to any non-Arabic speakers and the newcomers? Any non-Arabic speakers? Okay, so if I speak too much Arabic, raise a sign for me to repeat in English. If I speak too much English and you want me to repeat in Arabic, raise the sign so I repeat this in Arabic. خلاص agreed? Okay. طب let's start from the very beginning. Of course, you have the ILOs, and the ILOs is what we want you to know. And next year's book is going to see a replacement of these ILOs with the ILOs I have given you, because these are more updated and they are encompassing everything in the curriculum. Starting from the very first page, let me tell you something. Rule of thumb, generally speaking, general pharmacology is the most important chapter in pharmacology. Why? Because you are going to use it until the day you finish your studies and even afterwards. Even if you go for MRCP, FRCS, MRCOG, أي معادلة, أي زمالة, they ask you in general pharmacology, whatever may be your specialty. So it's very important. Okay? طيب. From the very first page, the only problem with general pharmacology اللي أنا كان دايما عندي مشكلة فيها حتى كطالبة, it's full of what? Examples. The problem with the examples is that you know nothing about this already. طب how are we going to do about this? I will tell you as we go along in which areas are examples important, and if I don't mention this as an important example, consider that you are not responsible. خلاص? Okay? تمام. Starting from the very first page, there is a definition for pharmacokinetics and pharmacodynamics, and I know that you think this is a very easy definition. What's going to be important about? What's pharmacokinetics? What is it? What? What's pharmacodynamics? What the drug does to the body. And I promise you, maybe in later books, you are going always to see the dynamics before the kinetics, غير اللي موجود دلوقتي, because dynamics is the main thing. It's what the drug does to the body. And kinetics, it's what the body does to the drug. Type. Like what kinetics? What does the body do to the drug? Four things. Absorption, distribution, metabolism, elimination. Type. What's so important about knowing the difference between kinetics and dynamics? It's important. You need to understand whatever you are seeing, whether it is kinetic phenomenon or dynamic phenomenon. Am I going to ask you in the coming exam about this understanding? Yes, I will. I will. And it will not be in writing. It will be in an MCQ question. MCQ questions will have something testing your understanding whether this is kinetics or dynamics. And as we go along, I'm going to explain more. Type. Passage of drugs across membranes. Just let me. Please don't take any note of these highlights. I mean nothing by these highlights. Okay? I mean nothing by the highlights. Okay? Highlights mean nothing. This is just important because this is a version that's highlighted. أنا هي اللي دي اللي فتحت معايا. Highlights have no significance for this presentation. Fine. Everything about the drug passage across membranes is very important. This is the basis of everything. The difference between simple diffusion and how it depends on a concentration gradient and the presence of carrier-mediated transport and how it depends on a carrier and the active transport and how it depends on energy and which of them requires energy and which of them requires a carrier with or without energy. This is all very important. I know it's very easy and it's very important. So this is to start with. Right. Here I have to stop at something. the degree of ionization as a marker of and its importance in drug solubility. We know for a drug to pass any membrane in the body, it has to be lipid soluble. And if the drug is ionized, will it be lipid soluble or not? It will not be lipid soluble. Do I want you to memorize the Henderson-Hasselbalch equation, this one? No, I don't want you to memorize it. Why have I put it? Let me explain. It says that, okay, for weak acids or weak bases, okay, the pKa equals the pH plus the log of the ionized over the non-ionized. What's so strange and peculiar about this equation? It's the word log. It's a log relation. Now, what does this mean? This equation tells you if you change the pH by 1 point, the ratio between the ionized and the non-ionized changes how many times? Do you know? Huh? 10 times. And why is this important for drug absorption? Because I can change gastric pH by 1 point. Imagine instead of the drug is 50% ionized, 50% non-ionized, it will become 10% non-ionized, 90% ionized by changing 1 pH point. So when you see an equation, you don't memorize it. بطلنا نحفظ، كله موجود قدامنا. We need to understand what's between the lines. Now, as a doctor, you are very well aware that if you give a drug and this drug needs, let's say, acidity for absorption, and you are not providing enough acidity, you are providing pH which is 2 points higher، يبقى الدواء ده الابزوربشن بتاعه قل كم مره بقى؟ 10 في 10 بكام؟ 100 مره. See how important it is? So this is what this equation tells you. So degree of ionization of a drug is very important. You need the drug to be non-ionized, to be lipid soluble. What does ionization depend on? It depends on the pKa of the drug. Its chemical nature. This is the nature of the drug. شكله كده. وايه تاني؟ والpH of the medium. And there's an equation that we don't need to memorize, but we know the name of the equation and we know the rule that 1 point change in pH changes the ratio between ionized and non-ionized how many times? 10 times. 2 points? 3 points? Yes. So you see how important? Very important. Now, next. Anything that has comparison is important. And on your ILOs, when I say compare, this is the highest level of intellectual ability that you have in this material. Compare. You analyze. You're comparing two things. So the question can tell you compare, and the question can ask you to describe one of them, because you already can compare. So you know how this is, and you know how this is. And you know how I study this? I study each one separately. And then I try to compare. Always try to do active studying. So again, this is very important, the difference between facilitated diffusion and active transport. Anything that's not clear today, we cannot explain every bit and piece in the curriculum. This is just 2 hours, okay? And it includes everything. But if you don't understand something, please raise a hand and tell me. Now we start with absorption. We continue with absorption. There are factors that govern absorption, like factors related to the drug, factors related to the water solubility, its ionization, its valency. Now here examples, okay, like you should know the example of iron. This is an important example. Okay, this is an example which is important. You should know that there is something called quaternary ammonium compounds, but not at your level. Maybe next year you should know about this. Not this time, not this year. Okay, again, the details about the only example I need you to know here is the example of iron. And there are factors related to the patient. Now we know about the routes of administration. في حاجة اسمها intravenous. Where do you put the drug if you give it intravenous? You give it in the circulation. So this should be the highest level of absorption. Of course, because you are actually giving the drug into the circulation. There is nothing higher. This is how much bioavailability? 100%. Now, the other ones are less. Of course, intramuscular is a little bit less. Why? Because it's not intravenous, but it's vascular. The muscles are vascular. Then the subcutaneous is less than the intramuscular because it is less vascular. And then the oral is even less. Why is that? Because the drug has to travel a long way. It will go to the stomach. There is acidity, and the intestine. There is alkalinity, and then there is the wall, and then there is the portal circulation, and then there is the liver. هيعدي كل ده. بس خلي بالك في drugs الاورال bioavailability بتاعتهم 99%. في أدوية الأورال bioavailability بتاعتهم 99%. So this is not a rule for all the drugs. Oral can be very good. Okay, so you should know the factors. Okay. Surface area is important, of course. Because the surface area is important, where is mainly absorption going to take place? Stomach or intestine? Intestine, because of the surface area. Because of the surface area much bigger. وهتعرفوا كمان او اكيد عرفتوا ان في intestinal villi ومايكرو villi كل ده increasing the surface area of absorption. Now, the motility of the drugs and the rate of absorption and the presence of food and everything. Okay, here you know the example of vitamin B12. You don't need to know any specific example of drugs. Like, I don't expect you to know about L-DOPA. What's L-DOPA? About tetracyclines, about cholestyramine. I don't expect you to know all these names. Unless I describe in the exam, I tell you this is so and so. You don't need to memorize these. Okay, so you don't need to memorize these examples. Grapefruit juice is important because it's not even a drug. So you should understand how it might increase the absorption of some drugs. And the important thing is it may increase the absorption of some drugs, but it may inhibit the metabolism, okay, at the liver. So it will be a hepatic macrosomal enzyme inhibitor. So grapefruit and anything that has food in it is important because this is not even a drug. مش مشكلة انكم تعرفوا اي حاجة related to food. And then there is the first pass effect. Now, what is the first pass effect? It's the first passage of drug, okay, through the lumen of the intestine and the stomach, through the wall and through the portal circulation, through the liver itself until it reaches systemic circulation. So any metabolism that happens during this pass is called first pass effect or first pass metabolism or pre-systemic metabolism. And some drugs have almost 100% pre-systemic metabolism. Nothing reaches systemic circulation. For some drugs, 10% reach systemic circulation, 5%, 30%, 50%. What do you think the application for this? نعمل ايه? What do we do if the bioavailability is only 5% or 10%? What do we do with the dose? We increase the dose. What about the intravenous dose? So in these drugs, is the intravenous dose equal to the oral dose? No. What if you give the oral dose intravenous? You get toxicity. So if you found drugs that have an intravenous dose, which is this much, and an oral dose, which is this much, you know this drug has what? First pass effect. Okay? In such case, there will be a dose for oral and a dose for intravenous. Perfect. عايزة بس أشوف أتأكد إن كله تمام. لا أنا هيبقى صعب إن أنا to repeat something. Okay. Maybe whoever wants questions, you can send me on WhatsApp. So bioavailability is again very important. As you can see, how can you calculate bioavailability? It is by dividing what? What by what? How do you know about bioavailability? Huh? I want to know the oral bioavailability of a certain drug. So what do? I get a patient or a healthy volunteer actually. حطه قدامي كده. He's here in front of me. And I give him, let's say, the dose intravenously is 100 milligrams. And I will give him the 100 milligrams intravenous. And then what do? I bring him next day. And what do I give him? I give him the same dose orally. What do I do afterwards? Huh? You take what? Plasma sample, because you want to know how much reach the systemic circulation. When do you take your plasma sample? With IV, the minute you give the drug, it's going to be in the sky. أعلى concentration. And then it's going to fade away. What about the oral? Huh? It's going to be slowly absorbed, reaches a peak, and then goes down again. So this is the shape for the oral, this is the shape for the IV. So is there a particular point that you can compare or divide to know the bioavailability? Is there? No, because the rate of absorption is not the same. It's not comparable. So what do? I trace this drug in plasma. I keep taking plasma sample, and I draw a curve. The curve is the concentration against what? Time. Concentration against time. Time in the x-axis, concentration in the y-axis. What does this curve tell me? It tells me about the whole residence of the drug in plasma. قصته كلها من أول ما دخل كان قد إيه لحد ما خلص. بعرف ده إزاي mathematically. I multiply the x by the y-axis area. Okay, I get the area under the curve. So what does the area under the curve tell me? Not just how much of the drug was in plasma for how much time. Get زرتك. I came to visit you once in a week. And I stay for half an hour. What if I come every day, but I stay only for 2 minutes? That's it. So you need to know how much time and what is the level of the drug or how much drug in plasma. So this is about oral bioavailability. Some definitions, any definition that you find is very important. Any definition is very important. Some have been marked in your ILOs for written exam. One of them is bioavailability. So you should know bioavailability by heart. And you should know volume of distribution by heart. And you should know all the doses definitions by heart. Okay, these are definitions that you need to know. Type, the distribution. Now, the drug entered the circulation. Now it's going to be distributed. The factors governing distribution are very important. Drugs with high molecular weight will diffuse or will stay? Will stay. Drugs tightly attached to plasma proteins will diffuse or will stay? stay. Small molecular drugs that are small molecules will stay in the blood or will diffuse? Will diffuse. If they are ionized, will they enter the cells or will they stay extracellular? Extracellular. What if the drug is lipid soluble? It enters every cell. It will enter every cell. Type. Some drugs don't do any of this. They go and hide in certain tissues. They go and hide in the bone. They go and hide in adipose tissue. Type. I want to know the dose to give that person. What is the importance of the dose? What is my main outcome? عايز أوصل لإيه? I need to attain a certain what? Plasma concentration. طيب, if I'm going to give the same dose of every drug, are they going to get me the same plasma concentrations? No, because they differ in what? In distribution. A drug which stays in plasma, I need to give a small dose because it only stays in plasma. A drug which goes to extracellular fluid, I will give a larger dose. A drug which distributes total body water, I will give even a larger dose. إذن, I need to know something called the volume of distribution of a drug. I cannot measure accurately how much of the drug stays in plasma, how much in extracellular, how much in intracellular, how much hides. I cannot measure this. I know one thing. I have given you a dose and I have a plasma concentration. I divide the dose by the plasma concentration. I get a number. This number signifies what we call the volume of distribution, even if this number is not realistic. No problem. It's the number that by which I multiply the plasma concentration to know the dose that will fill the body. That's why we call it what? Loading dose. So you need to know the patterns of distribution, how the drugs differ. You need to know the factors which govern the distribution. And you need to know the application in case of the volume of distribution. As you can see, distribution differs with the physicochemical properties, molecular weight, ionization, lipid solubility, binding to plasma proteins. Okay? The bit about hypoalbuminemia is a little bit difficult. I will not ask you about it. The bit about hypoalbuminemia is a little bit difficult. I will not ask you about it this time. Passage across barriers is very important because your brain is protected by a blood-brain barrier. Drugs will differ in the degree those lipid-soluble drugs will pass the blood-brain barrier. Okay? Less lipid-soluble drugs and ionized drugs will not pass the blood-brain barrier as much. However, in some cases, there will be inflammation of the CNS or inflammation of the meninges. What happens with inflammation? Do you know? Vasodilatation. And the barrier will be weaker. And there will be wide blood vessels and wide gaps between the cells. So some drugs can pass, especially when you use antibiotics for meningitis. So this is an application for distribution. What else is an application? Placenta. Of course, placental barrier is very important because some drugs, okay, pass to the fetus, and some of them are injurious, especially in the first 3 months. طيب. Breast milk. Now, this is very important. Most drugs administered to lactating women are detectable in breast milk. We can find them in breast milk, but let me tell you about an example which is very important. pH of milk is 7. pH of plasma is 7.4. What if this drug is a slightly basic drug? Will it be more soluble in plasma or more soluble in breast milk? Drug is basic. Plasma is 7.4. Milk is 7. Which is more acidic? Milk. The drug is basic. تمام. Drug is more soluble in milk or in plasma? Plasma. So it will enter the breast milk. What will happen when the drug enters the breast milk? It will become more ionized or less ionized? It will become more ionized because there is 0.4 difference in pH. The drug becomes more ionized. So what happens when it becomes more ionized? Will it be able to get back to plasma? No. So what happens to the drug? It is trapped inside breast milk. Imagine if this drug is very basic, okay? And we said that a difference between pH and pKa of 1 equals 10 times. 2 equals 100 times. Can you imagine how much drug this baby, suckling baby, is getting? It's not getting the same dose as the mother. It is getting 10 times bigger or 100 times bigger what his mother is taking. So is this important? Very important. So you know the breast milk is acidic or alkaline? It is more acidic than plasma. So for alkaline or basic drugs, they will enter the breast milk. What happens to them? They become ionized. Once ionized, can they escape? No, this is called ion trapping. Very dangerous, very important, because it's not about the passage in breast milk, it's even concentrating the drug in breast milk. Okay, tamam. Now, apparent volume of distribution, I told you why that we calculate a volume of distribution is just a number, why it's called apparent, and I will explain this next year, inshallah. لحد دلوقتي, what you need to know are the patterns of distribution, what's volume of distribution called, and all about the loading dose, okay, and how you calculate it. Okay, significance of volume distribution is again important. It is important to, okay, rough estimation. Now, this is important. This is very important. Now, when I give a person dose of a drug, and then I measure a plasma concentration, I divide the dose by the plasma concentration. What do I get? Volume of distribution. طيب لو لقيت الفوليوم of distribution ده مثلا 5 لتر. So what does it mean? This drug distributes where? In blood. It doesn't leave the blood because I have given a dose. I divided the dose by the concentration and I get a volume of distribution of 5 liters. طيب, what if I get a volume of distribution of 20 liters? يعني تقريبا a quarter or 20% of that patient's weight or volume. Where is this drug going? Extracellular space. So this is a drug that distributes in extracellular space. طب what if I get a volume of distribution of 50 liters? This drug is entering every cell. طب what if I get a volume of distribution of 300 liters? Is this understandable? Why did it happen? The drug is hiding. What happened is the drug, it went and it hid in the CNS, it hid in the thyroid, it hid in the heart, in the bone, and I cannot find it in plasma. The concentration in plasma is very small. So what do I do when I calculate the volume of distribution? I divide the dose by the concentration. So if this concentration is very small, I will get a small number or a big number. A very big volume of distribution. It's just apparent. This is just apparent. It has no meaning. It just tells me this drug is hiding somewhere. It has a special distribution. طب, you can know this next year بقى إن شاء الله, or if you are interested to read package insert, they tell you the volume of distribution of a drug is 2 liters per kg. How can it be 2 liters per kg? هو فين الكي جي اللي فيه 2 liters? 3 liters per kg, 7 liters per kg. This is a drug which is hiding somewhere. Okay, so you might be asked about the significance of volume distribution and how it tells you about the distribution of a drug. Determining the loading dose. Now we come to metabolism. The metabolism, which is the main organ? The liver. But I need you to know that it's not only the liver that metabolizes drugs. You need to know that the liver is the main organ of metabolism, but again, it's not the only organ of metabolism. So you need to know that drug might be metabolized in the kidney, might be metabolized in the lung, might be metabolized even in plasma, many areas. In GIT, of course, types of metabolic reactions, you have phase 1 and phase 2, and let me ask you, because I know you know about this. This is again a comparison. If it's a comparison, then you need to know it very well, and you need to know each one separately. But phase 1 and phase 2, which one occurs first? Which one occurs first? Huh? Which one occurs first? No rule. No rule. تمام؟ طيب. Phase 1 and phase 2. Which one always inactivates the drugs? No rule. No rule. طب what's the very clear difference between phase 1 and phase 2? كل حاجة هقولها لك هنقول لك مش شرط. مش شرط. مش شرط. ايه الحاجة اللي شرط؟ Phase 2 is synthetic. There is conjugation. And why is this? Why is the liver metabolizing drugs? الليفر قاعد بيفكر وعنده مخ وقال لك ده دواء and I will metabolize it? No. What does the liver do? And why is it doing it? The liver is simply converting foreign or sometimes even endogenous lipid-soluble compounds into water-soluble compounds. Why? Because the kidney is the ultimate way of getting drug out of the body. Any drug which enters my body has to get out. Now, how is the kidney going to get rid of a lipid-soluble drug? It is impossible because the drug will be filtered. After being filtered, it will be reabsorbed and then reabsorbed and then reabsorbed because it is lipid-soluble. So the liver doesn't think. The liver is simply converting lipid-soluble to water-soluble, non-polar to polar compounds. To do this, the ultimate step is synthesis. حط عليه glucuronide, acetate, whatever thing you want to put. Then most probably, it will be خلاص water soluble. It can be excreted by the kidney, and كمان most probably it will be inactivated with very few exceptions. Morphine is an exception. I don't tell you to memorize again the name of the morphine metabolites, but you just know that there are exceptions. Even with glucuronide conjugation, things might be more active because the liver is not inactivating, it's just converting. Type. Sometimes you can attach this glucuronide or you can attach this acetate. It is easy. You can attach it. Sometimes the molecule of the drug is like a ball. Can you attach something to a ball? Where? Huh? Where is it going to be attached? You cannot. So there must be a functional group. That's why there is a phase 1. And that's why there's no rule. Maybe the drug is suitable for phase 2 على طول. Maybe the drug will undergo phase 1, then becomes water soluble and is excreted. That's why there's no rule. Some drugs have phase 1 only. Some drugs have phase 1 and phase 2. Some drugs have phase 2 right away. Some drugs undergo phase 2 and then undergo phase 1. There is no rule. But phase 2 produces more inactivation and it is always synthetic. تمام؟ A drug in phase 1, oxidation, reduction, hydrolysis, can be changed into an inactive drug or more active, or it might be a pro-drug that becomes active, or it might be more toxic. You know this just as a rule. Next year and the year after, you will get specific examples. And we will remind you about this because the specific examples are then going to be very important. حلو كده؟ تمام؟ هتقعد تقول لي بقى هيدروكورتيزون ودايزيبام و don't memorize examples, just the rule. Responsible for metabolism, microsomal, non-microsomal. Again, this table and comparison is important, especially with the cytochrome P450 and how it can be inducible, how it can be induced. Hepatic macrosomal enzyme inducers and inhibitors. Now, these examples I need you to know. خلاص, let's agree that for hepatic macrosomal enzyme inducers and inhibitors, you need to know them. Okay? You need to know them. Especially if they are not drugs. But you need to know them. So we have phenytoin, carbamazepine, and rifampicin. Phenytoin and carbamazepine, these are anti-epileptic drugs, drugs against epilepsy. And rifampicin is an antibiotic against TB. Inhibitors like grapefruit juice, sodium valproate, this is again an anti-epileptic drug. Erythromycin, this is an antibiotic. Omeprazole, this is an anti-ulcer treatment. It's anti-acidity drug. More important than the names, though, I need you to know what's the effect of an enzyme inducer or enzyme inhibitor. What if I give you drug A and then drug B is an enzyme inducer? What will happen to drug A? What's an inducer, by the way? Inducer will increase the synthesis of enzymes. Synthesis and activity. Inhibitor will inhibit the activity of enzymes. Type. What if there is an inducer? Drug B is an inducer. What will happen to drug A? Level will decrease. Effect will decrease. Type. What if I give you drug A and drug B is hepatic macrosomal enzyme inhibitor? What will happen to drug A? Level will increase. Might be toxicity. This is what I need you to know. Another bit. Inducers will induce their own metabolism. يعني أنا كده عندي patient epileptic بتاخد carbamazepine or phenytoin. على فكرة, if I tell you something with these names, I'm going to say what it is. But you just recognize these are enzyme inducers. طيب, she's on carbamazepine. Today, she has good plasma concentration. I always measure the plasma concentrations. After a week or two, I measure her plasma concentration and I find it lower. What happened? Carbamazepine induced its own metabolism. So I may have to increase her dose. So you need to know that glycosomal enzyme inducers can induce their own metabolism. This is called auto-induction. Auto-induction. Another name for it is kinetic tolerance. Kinetic tolerance. Because they start to decrease their effect decreases. We call this tolerance. Okay, they are not doing the same effect, بس بسبب ايه؟ بسبب presence of kinetic phenomenon. عشان كده قلت لكم لازم تفرقوا بين الكاينetics والداينامكس. هنا دي kinetic tolerance. ليه kinetic tolerance? Because this is enzyme induction. The effect is on the liver, on the metabolism. طيب, يبقى كده we said about hepatic macrosomal enzyme inducers. Other factors that affect the enzymes, like extremes of age, like the presence of androgens, they are enzyme inducers, estrogen, enzyme inhibitor, pathological conditions, sometimes liver disease, starvation. All these effects are important. You just need to know their effect on metabolism. However, something very important are the genetic factors. Next year, there will be a chapter for first year called pharmacogenetics and genomics. 1 or 2 pages. You already know about this. Are we all genetically the same? We have different colors of eyes, different colors of skin, different hair, right? Okay, so do we have the same enzymes? Do we have the same receptors? No. So sometimes people tell you, I get side effects of every drug. And some other people, they take the same drugs and they complain of nothing. صح? This is due to genetic variability. When this genetic variability is quantified and we know its percentage in the population, we know this is pharmacogenetics. And some examples are very famous. Like, we call this genetic polymorphism. There are multiple genetic types with variation in response. Don't memorize the example, please. Don't memorize the example. Just know that genetic variability will result in differences in drug action, so in kinetics or in dynamics. And we call this genetic polymorphism, or we call this idiosyncrasy, as you'll see in adverse effects. Now we come to the kidney. Now, the kidney eliminates drugs by how many processes? Sum of how many processes? 3. Filtration, secretion, not excretion, secretion, and reabsorption. Can you tell me something about each one? If you want to say something about filtration, what do you say? Huh? I need one most important fact about filtration. Small sized molecules that are attached or not attached to plasma proteins. Not attached to plasma proteins. So this is filtration. Tell me one important thing about secretion. Secretion needs. يعني ايه secretion؟ يعني الدواء ده مش filtered ولا ماشي بosmotic gradient. No. These are carriers that take the drug زي الشيال كده هيلا بيلا from the plasma side into the urine. تروح رمياه في اليورين بالعنية deliberately تنقيهم. So there is a carrier for secretion. Do you know how many carriers there are? 5 10 كتير على قد الأدوية اللي ربنا خلقها. 1/4 acidic drugs and 1/4 basic drugs. Hey, what does this mean? What important application? This is a site for competition between drugs. You give me a drug dose, there is secretion, تمام حلو جدا. Then you give me another drug that competes with this drug for secretion. What happens to drug A? Level falls or rises? Level rises. Why? Because it cannot be secreted as efficiently. So you have 2 carrier types in secretion. Secretion يعني دواء هيلا بيلا من البلازما to the urine against its concentration gradient. Active secretion. 2 carriers. Drugs compete for the carriers. So an application for secretion. Tell me one important thing about reabsorption. It is for ionized, non-ionized, lipid soluble, non-lipid soluble. Reabsorption into the circulation. This is the opposite of filtration and secretion. Filtration and secretion رايحين فين؟ out. Reabsorption رايح فين؟ in. The algebraic sum of the secretion, reabsorption and filtration المحصلة gets me the excretion. So the excretion is the whole sum of filtration, secretion, and reabsorption back. So what's important word about reabsorption? That it involves what? Lipid-soluble drugs. What if I give you aspirin? Do you know aspirin is acidic or alkaline? Aspirin is acidic. Do you know whether urine is acidic or alkaline? It's acidic. So aspirin dissolves in the urine, which means that aspirin will be reabsorbed. I give you a dose of aspirin, some of it will be reabsorbed. Now, what if you have aspirin toxicity? How can I increase the excretion of aspirin? I'm going to do what in the urine? Tap. You are going to alkalinize urine. How does the Henderson-Hasselbalch equation explain this thing that you will do? Aspirin has a pKa. You are going to elevate the pH above the pKa. And you are going to increase the difference between the pH and the pKa. And according to Henderson-Hasselbalch equation, each point in pH is going to increase ionization of aspirin. How many times? 10 times. Aspirin becomes ionized because urine is now not as acidic. It is alkaline. So what if it is ionized? It means it will be what in urine? Trapped in urine. So again, this is ion trapping. This is another application of ion trapping. So kidney, 3 processes. Filtration, small non-protein bound molecules. Secretion, 2 carriers, 1 acidic, 1 basic with competition. Drugs that compete, they will decrease each other's excretion because they will decrease each other's secretion. What about reabsorption? Passive process, lipid-soluble drugs. So if there is a fixed amount of drug that will be reabsorbed, I can manipulate this. If it's an acidic drug, I alkalinize urine, I increase excretion. I acidify urine, I increase reabsorption. If it's a basic drug, I acidify urine, I increase excretion. اوكي؟ فهمنا؟ تمام؟ ماشي. اللي بعده. طبعا زي ما قلت في الميتابوليزم بالظبط, the liver is the main organ for metabolism. What is the main organ for elimination? Kidney. Does it mean that the kidney is the only organ for elimination? No. Drugs can be eliminated through the lungs, through the sweat, through the milk, through even the GIT, through the biliary passages. The biliary passages, they have secretion just like the renal tubules. Some drugs are secreted through the biliary passages. Fundamental principles of kinetics. When you see something like this, is this important? It's very important. And it's a comparison. And if I tell you a comparison, this means I might ask you about each one separately. What's the difference between zero order and first order kinetics? Are these types of kinetics? Well, صعب. ذكي قوي. Are these types? يعني some drugs, they have first order kinetics. Some drugs have zero order kinetics. Is this what it is? These are states. What does it mean? As long as you give me a small dose and I have ample enzyme, ample carrier enzyme زي ما انت عايز, as much as you want. This is a chemical reaction. Chemical reaction لما خدته في إعدادي, it is going to proceed according to the concentration of the reactants. The more drug you give me, the more metabolism I will do. The more drug you give me, the more excretion I will do. This is because the dose you give me is very small compared to my capabilities of metabolism and excretion or elimination. صح؟ طيب. What if you increase this dose. You increase and increase and increase until you saturate my enzymes and carriers. In the first state, first order kinetics, I could metabolize or excrete or eliminate a fixed percentage per unit time. In an hour, I will clear 30%, whatever may be this 30%. In 1 hour, I will clear 20%, 70%, 80%, whatever. So it's a constant what? It's a constant percentage. But now you have saturated my enzymes and carriers. I tell you, I cannot keep up with the percentage. I have a limited what? Amount per unit time. Beyond this amount, the drug will accumulate. You have 2 examples for this, and the examples are important. Aspirin, large dose, phenytoin, large dose. What was phenytoin? Drug for epilepsy. And aspirin, why do we need to use aspirin large dose? For rheumatic fever. And I will tell you something. We choose drugs that have first order kinetics. We don't want drugs that enter into zero order kinetics. We don't use them. We still use phenytoin. Why? In spite of the fact that it enters zero order kinetics, it touches on zero order kinetics because it's very effective. Huh? Yes, it treats epilepsy and it's a cheap drug and it's still effective and it is still used in spite of the fact that it can enter zero order kinetics. It can undergo accumulation. The dose that we give is large relative to the enzymes and carriers that we have. اتفضل. الايه؟ الفينيتوين وايه؟ ethanol برضو in large amounts بس احنا we don't use it for treatment. That's why it's not included as in drugs, because the toxins, they are reaching zero order kinetics, and that's why we call them toxins. That's why we call them toxins. مش عشان التوكسينز هم zero order والأدوية first order. لا، هم أدوية عشان هم first order. وهم toxins عشان هم zero order. It's the other way round. طب what about aspirin? We are a country that uses aspirin in very large doses because of rheumatic fever. العالم كله they are using aspirin 75-150 milligrams for protection of the myocardium or decrease platelet aggregation. This is a small dose of aspirin. It's not zero order. But the dose of rheumatic fever can enter into zero order and result in aspirin toxicity. So now you understand the difference between zero and first order? Okay? تمام. You memorize this by heart. طيب. You are not required to memorize these equations. Even next year, I bring the problems with the equations. Huh? Paper A. مش هديك مسائل خالص. السنة دي أنا السنة الجاية ما عنديش غير مسائل. ما تقلقش خالص. مر على رزقك. اتفحتوا مسائل السنة دي. خدوا 12 مسألة. سنة تانية. Half life. طيب, what's the story of half life? Again, this is very important. What's the story of half life? If I tell you a drug follows first order kinetics, خلاص بقى أنا كده إيه؟ بدي الكلام كده بسم الله الرحمن الرحيم. This drug is in a state of first order kinetics. So this drug has a constant what? Elimination per unit time. Constant percentage per unit time. يعني 30% per hour. 20% per hour. طيب, I will flip it. I will need you to tell me how much time it takes for the drug to reach 50%. It is exactly the same thing. So if there are two faces of the same coin, أما أقول لك this drug follows first order kinetics, it means that there is a constant percentage eliminated per unit time. Let's say it is 50% eliminated per unit time. Okay? تمام? Or 30% eliminated per unit time. I can ask you the other way around. How much time does it take for a drug plasma concentration to reach its 50%? This we call it what? T-half. All is very important. Applications are very important. Now, let me tell you more about the T-half. أول حاجة, this is very important for you to understand. When we say T-half, reducing plasma concentration to 50%, the time needed for the plasma concentration to reach 50%, we expect this to signify the amount of drug in the body. And the plasma concentration is just a reflection of the amount of drug in the body. So when we say, of course, it might vary because some drugs will have more than one T-half. So when we say, if we say the T-half, we can say, if I tell you the time needed for the plasma concentration to drop to 1/2 or the amount of drug in the body to drop to 1/2, this is what? This is, again, this is a definition of the T-half. Type. Imagine with me, I give you a dose 100 milligrams. After 2 hours, 100 milligrams gets you a plasma concentration that goes to 50%. So the T-half is 2 hours. After 4 hours, how much do I have in the body? It is 50% of the 50%. So I'm left with the 25%. Then another 2 hours. This is the 30 half. 50% of the 25. So this is 12.5. Then the 40 half, I'm going to get 50% of the 12.5. This will be around 6%. With the 50 half, only 3% remain. We consider this khalas, the drug is disappearing. So the drug under first order kinetics, no matter how high the concentration is going to disappear after around 4-5 T-half. طب ركزوا بقى معايا بقى for this coming. What if I decide to give you regular dosing of this drug, which is first order kinetic elimination? يعني ايه first order kinetic? يعني the more I give you, you metabolize. The more I give you, you metabolize. The more I give you, eliminate. The more I give you, eliminate. So constantly, whatever I give you, you are getting rid of it. So after the first dose, after lapse of 4-5 T-halves, what happened to the very first dose? Completely disappeared. So after the first dose disappeared, and I'm giving you regularly, you will have constant or fluctuating plasma concentration. You will have a steady state concentration. So for a drug on first order kinetics, constant T-half means that you are going to reach steady state after 4 or 5 T-halves. And if you stop the drug now, the drug will disappear after how much time? 4 or 5 or almost 5 T-halves. It will be less than 3% in the circulation. تمام. تمام. طيب. This is very important in dosing because this is what we need is the steady state concentration. One more thing. I might give you this dose as an infusion, in which case this steady state concentration will be a straight line. البتاع معلق وفي constant rate. تمام؟ However, I usually give you repeated dosing. Yeah, I give you repeated dosing. So when you reach the steady state, it will be like this. But it's constant. It has a constant average. So the steady state may be a line, or the steady state may be like this, but it has a constant average. تمام? So again, this steady state is very important. طيب. سؤال بقى. Is there a constant always, is there always a constant relation between the T half and the duration of action of a drug? Yes or no? Yes or no? دايما ال duration of action يمشي مع T half. Why؟ عايزه بقى اللي هيقول بقى الاجابه دي. الاجابه دي في اول صفحه. What's the action? Is it kinetics or dynamics? It's dynamics. What's the T half? Is it kinetics or dynamics? Huh? When you're talking T half, you're talking about a kinetic phenomenon. When you're talking about the duration of action, you're talking about a dynamic phenomenon. We are going to tell you now that drugs act by many ways. Some drugs act at the level of genes. الدواء نفسه ما بقاش موجود في الجسم, but its action is there. Or the drug is there and there is tolerance. The receptor is down-regulated, there is tolerance, there is resistance, there is addiction, there is whatever. So, basically speaking, أيوة, the longer the T half, the longer the duration of action. The shorter T half, the shorter the duration of action. But there are a... Why? Because this is a kinetic phenomenon and the other phenomenon is a dynamic phenomenon. See why you need to understand the difference between kinetics and dynamics? Important. طيب. So everything here is the loading dose is very important. You need to know about it. You need to know how to calculate it. Now, why is the loading dose important? Let me explain. That when do you reach a steady state concentration? After how many T halves? Type. Let's say this drug has a T half of 2 days. When are you going to reach a steady state concentration? After a week? Type. What if the state of the patient is urgent? Patient with heart failure. What do? You wait for 5 T halves? لا, you need to load the patient. You need to load the patient. So you give a loading dose to reach a plasma concentration rapidly. طب how you calculate this loading dose? You can tell me this concentration and tell me what? The volume of distribution. Then I multiply the plasma concentration by the volume of distribution, and so I know the dose that I should give the patient for loading. And when do we need loading? We need loading when we cannot wait for 4 to 5 T halves. We need to build the plasma concentration rapidly. So we need to give loading. كان في سؤال هنا. سؤال؟ بس عشان احنا بنمشي بيس بقى أسرع شوية عشان نضمن إن احنا نخلص. Maintenance dose again. Maintenance dose. Maintenance dose that you need to maintain. I will explain this more next year. Just a glimpse. What is there in the equation of the maintenance dose? When you see an equation, don't memorize it. Try to ask what this equation is trying to tell you. In a multiplication like this, you multiply the steady state concentration mainly by the clearance. What is the clearance? Clearance is for this one, you need to know a definition. Clearance is the volume of plasma cleared from the drug per unit time. يعني لو الدواء ده متوزع في فوليوم 5 لتر distributed in, let's say, in 50 liters in the body. Now, the kidney is excreting this drug. How many milliliters are cleared each minute? It is not something you imagine because the kidney is not taking مثلا 10 milliliters or 100 milliliters separately. But we express it this way. يعني الكدني is not going to take 100 ml 100 ml 100 ml لوحدهم وتفصلهم وتفلترهم. لا. بس this is the way we express clearance. So if you know the amount of fluid cleared per unit time and you know the concentration that you need to keep in this fluid, you multiply it, you get your maintenance dose. Anyway, it's a bit difficult for you, so we can reserve it till next year. Just know that for the maintenance dose, you need to know the clearance and the steady state. Okay? This is what you need to know. عايزة أبطل أمشي كده. طيب. ماشي. أخيرا وصلنا للداينامكس. Just as we said, in excretion, the most important organ is the kidney. In metabolism, most important is the liver. Drug dynamics, most important mode of action is through receptor, but there are other modes of action and they are important and you should be able to enumerate them. Know that some drugs act physically, some act chemically, some interfere with cell division like anti-cancer drugs, some interfere with the metabolic pathway, some produce enzyme inhibition, some inhibit carriers, and most of the drugs, they act on specific receptors. Okay? ماشي. أنهي examples اللي فين؟ لا ما تحفظهاش. ما تحفظوش الريت ثيوري والاوكيوبيشن ثيوري. اوكي؟ ما تحفظوش الريت ثيوري والاوكيوبيشن ثيوري. لكن اللي مهم قوي the drug relation between the drug dose or the concentration and the response or the effect. دي المرة الكام اللي احنا نشوف كلمة log. المرة الثانية. ولو انتوا جدعان قوي في الكاينetics هتعرفوا، بس مش at the level of the undergraduates، تعرفوا كمان ان concentration time ده log relation. فالlog relation ده مهم قوي. Why? Because if I give you a dose of the drug, it will act on a number of receptors. Then I increase the dose. The excess of the drug is going to act on the remaining receptors. تمام؟ On the remaining receptors. So it's again the log phenomenon. زي كده ما elimination 50% of 50%, 50% of 50%. Same thing. هنا الدواء ده تلاحظوا ان الكيرف ايه is like reaching a plateau. Why is this? Because I gave a dose or a concentration. It's acting on a number of receptors. If I increase the concentration, it will act on the remaining receptors. Okay, so we signify it by a log concentration response curve. The important one is this one. This one is very important. Okay, when we give a drug, there are definitions like affinity, efficacy, agonist, antagonist, dissociation. These are very important terms. What's affinity? It's ability of a drug to bind to a receptor. But to produce effect, this drug must have intrinsic activity or efficacy. When a drug has affinity and intrinsic activity, this drug is an agonist. When a drug has affinity with no activity, it is an antagonist or a blocker of the receptor. Now, what's potency? Potency tells me the relative effect of drugs compared to each other. يعني مثلا, if this is a response in the form of a rise in blood pressure or a rise in heart rate, as you can see, there is a maximum that you reach. The maximum is determined by the amount of receptors I have. These are the amounts of receptors, the maximum. There is nothing above this, nothing above this. This is stimulating most of the receptors. Okay? However, some drugs will be more potent. Okay, so they need smaller doses to produce an effect. Some drugs will be less potent. You need to use bigger doses or bigger concentrations. But how to compare this? We need to fix something. So we fix the 50%. We fix the 50%. 50% of what? Of the maximum response. And we call it the effective dose 50 or the ED50. And we compare the doses of the drugs. which is more potent, higher ED50 or lower ED50 drug? The lower, the more potent. For your practice, potency is not that important as long as you can always increase the dose and reach what? The maximum effect or the efficacy of a drug. The maximum effect. تمام؟ طيب. So this is what? This is drug A, B, and C. As you can see, drug A produces same effect with lower doses. So drug A is the most potent, and the last one is the least potent. You need to know all these definitions: definition of agonist, antagonist, partial agonist. If you're going to be asked, you're going to be asked in an MCQ question. So you don't need to memorize or write about the partial agonist. Okay, so this is for you. You need to know nothing about inverse agonist. Cancel it. Don't even read it. This comparison is very important. It is the effect, okay, of an antagonist on the agonist. Now, what is competitive antagonism? Two drugs are competing. They compete with each other. ايه ده؟ Examples like here? No. No examples in this table. Just know what competitive and know by heart the types of antagonism. Competitive بقى, non-competitive, reversible, irreversible, physiologic. Know them by heart. فهم وحفظ. Competitive antagonists, the drugs, they compete with each other. واحد بيزيح التاني. They kick each other out of the receptor. So if you give me a competitive antagonist, you're going to decrease my potency because you're going to shift my curve to the right. However, if I increase the dose of the agonist, I'm going to reach the same maximum point or same efficacy because the receptors available are the same. However, if you give me non-competitive antagonists, it's going to take out some of the receptors. It will decrease the potency and it will decrease, most importantly, the efficacy. It will decrease the maximum that I can reach because non-competitive antagonism is subtracting some of the receptors. They are not even available anymore. Physiologic antagonism, you are acting on a completely different receptor. Irreversible, read it and know about it and study it by heart. تمام؟ Okay, جدول اهو. Chronic use of drugs affects number and sensitivity of receptors. Agonists will result in receptor down regulation, and the antagonist result in receptor up regulation. Receptor down regulation will result in tolerance. يعني ايه tolerance؟ يعني failure of effect or decrease effect. دي kinetic ولا dynamic بقى؟ dynamic. امال كانت ايه kinetic tolerance؟ enzyme induction. تمام؟ Yes. The examples in the table. No examples here. No examples here. Now, types of receptors and signal transduction, for me, know it by heart. By heart. No one is going to teach you this except the pharmacology department. Yes. Now, drug what? Drug intolerance? Drug intolerance في the adverse effects بقى. لما نيجي الادverse effects. Intolerance يعني super sensitivity. Okay? Tolerance kinetic ودynamic tolerance. Dynamic tolerance على الريسبتور. يعني ايه؟ اديت اجونست كتير ريسبتور داون ريجوليتد، ده dynamic tolerance. يعني ايه dynamic tolerance? You give the drug and it's not acting anymore because the receptors are down regulated. الجسم دايما يعادل الحاجة. There is feedback. So if you're giving me agonist, the receptors will be down regulated. The receptors will decrease in number. So it causes tolerance. طب ده kinetic ولا dynamic? Dynamic. However, enzyme induction, this is kinetic tolerance. تمام؟ طيب. By heart, with the examples, with the timeline, with the details, with every word. You're going to use this everywhere. So the ligand-gated ion channels, they are just receptors and ion channels. When a ligand binds the ion channel, it either opens the channel or closes the channel or whatever. Okay, so examples like nicotinic receptors of acetylcholine, they lead to increased sodium influx and depolarization. GABA receptors open chloride channels, chloride influx results in hyperpolarization. So the acetylcholine nicotinic receptors are stimulatory receptors. However, the GABA receptors are inhibitory receptors. They inhibit the CNS. هتعرفوا بعد كده ان المخدرات كتير جدا منها بتشتغل على الجابا receptors and they result in addiction. These are CNS depressants. Yes. ها مالهم؟ Benzodiazepines work on GABA receptors. Opioids, they have their own receptors. G protein coupled receptors. These okay. G protein coupled receptors اتعملت ليه؟ Because the ligand cannot enter into the cell. So the ligand binds something or a unit outside the cell, and then there is a transduction of signal and second messengers. So what is the function of the second messenger with the G protein? Signal amplification. You have one receptor binding في cyclic AMP بقى وphosphorylation وكالسيوم بيزيد تلاقي السيجنال ايه amplified in the cell. Okay, so this is the G protein coupled receptor. Subunits, types, examples by heart. Enzyme linked receptors, these again like G protein coupled receptors, they have an extracellular domain and a cytoplasmic intracellular domain. However, the difference is the intracellular domain itself is an enzyme. Okay, it will excite a cascade of reactions as well, but the intracellular domain itself is an enzyme. That's why they are called enzyme linked receptors, and the examples are important, including the receptor for insulin. I think it's there. What examples do you have? Okay, insulin. Yes. Active, okay, gene active intracellular receptors. These are small molecules. They have to be lipid soluble. They enter into the cell. The receptors are inside the cytoplasm or intranuclear receptors. That's why they will regulate DNA synthesis and messenger RNA formation. So which is the fastest type? Ion channel. And which is the slowest type? Gene coupled receptors or nuclear and cytoplasmic receptors. Adverse reactions, definitions, classification, definitions. But good news is you are not required to define them. You are required to recognize them. يعني what's important here? Difference between type A and type B. Type A are augmented, they are predicted, they are expected. Okay? Yeah. الميكانيزم اللي هو ايه؟ ها؟ ريسبتور احفظه صم. صم كده صفحة كده ولا هما صفحة؟ ولا صفحتين؟ صم. ماشي؟ طيب examples here, you don't need to memorize the examples, because if I will bring you an example, I will bring you an example and I will describe it. يعني I want you to know that type A reaction is predictable. It is related to the mechanism of action of a drug. It might be a side effect. There is a normal dose of the drug. You get a side effect. زي كده ايه ما تروح تشتري something, okay, you buy something, some vegetables, and you need to take something bad with whatever you are buying. You have to buy it all as one lot, okay? This is a side effect. However, sometimes the patient receives a higher dose, or there is accumulation, or there is receptor upregulation or enzyme inhibition, kinetic or dynamic what? Super sensitivity. And I want you to know the difference between super sensitivity and hypersensitivity. Are they similar? Completely different. Super sensitivity, it is exaggerated response to a normal dose or concentration. Might be due to receptor upregulation, enzyme inhibition, increased level, whatever may be the cause. Hypersensitivity, this is type B. This is allergic reaction involving antigen antibodies. Okay? تمام. So, secondary effect is something you get because of the drug. Like if you give an antibiotic, you're going to kill good organisms and you're going to get super infection. Again, if I'm going to give you an example, I'm going to explain it. And super sensitivity, exaggerated pharmacological action to the response in response to a small dose. Drug intolerance, this is when it's a severe toxic effect. Now, this word is good to know about. Tolerance to a drug. Patient is tolerating the drug or not tolerating the drug. Sometimes the drug is very effective. Drug is effective. You give it to your patient is not tolerating the side effect. So you need to stop the drug. So the word intolerance means that the side effects are so severe that you need to stop this drug. Patient is not tolerating. Direct toxic effect, like if the drug is cardiotoxic, hepatotoxic, nephrotoxic, okay, neurotoxic. You don't need to memorize these because you will know them by the time you have finished pharmacology. These are very famous examples. When you know paracetamol, you will know that can be hepatotoxic. When you know non-steroidals and aminoglycosides, you will know they are nephrotoxic. So you don't need to know that now. ها. المين ده؟ انهي فين؟ شاوري. الجدول احفظي ان ده ممكن يحصل. اوكي؟ لكن ما تحفظيش مين اللي بيعمله. خلاص؟ البيزار بقى التايب بي الرجي هايبر سنسيتيفيتي دي صم بقى. صم تحصلش on first exposure، تحصل on second exposure، ممكن تبقى in the form of anticarya، ممكن تبقى form of anaphylaxis، غالبا فيها antigen antibody reaction، يا اما reaction to a drug or a prodrug او واحد من الدواء نفسه بيشتغل انتيجين او بيشتغل حاجه يعني anyway بيطلع immunoglobulin E، وعمرنا ما بندي الدواء تاني. That's why it's very important to take drug history from the patients. عندك حساسية من أي أدوية. Idiosyncrasy, again, this is very important because it's about genetics. As I told you, unpredictable non-response due to genetic abnormality. We are not similar. Okay, if we have a certain percentage of the population, 1%, 2% genetically different, we call this genetic polymorphism. These people will respond differently to some drugs. Sometimes this difference is important enough to test genetically before giving the drug, and sometimes it's not. بس أنا مش هسألكم عن كل التفاصيل دي، بس يعني إيه idiosyncrasy علاقتها بالجينetics. وهنا أنا عايزة ال first example اللي هي الهيموليتيك أنيميا with favism. The first example only. Other effects like tolerance, okay, just know the definition. What is tolerance? I don't care about animal tolerance. Inter-individual, again, this is about genetics. warfarin, don't memorize. Clopidogrel, don't memorize. Warfarin, we're going to teach you this next year. Acquired tolerance, yes, this is important. Read about it. It is easy. I will not ask you about the examples. Only the mechanisms, only the definitions, only the differences. No examples here. The meaning of dependence, meaning of habituation, physical dependence, addiction, just the definitions. Iatrogenic disease, it is the disease caused by drugs like Parkinsonism, like Cushing syndrome. Know about, here you know the examples, okay? But don't memorize the drug, okay? That there's something called drug-induced Parkinsonism. You don't need to memorize the name of the chlorpromazine. Cushing syndrome, however, is important as an example as well. Delayed effect teratogenicity is important. Know only about thalidomide, only thalidomide, because you will not take it in any other chapter. Know about thalidomide, okay, because you will not take it again. It is used now clinically, but we don't teach it. Mutagenicity. What's the difference between teratogenicity and mutagenicity? This is important. What's the difference between teratogenicity and mutagenicity? اصحوا يا جماعة، نمتوا ليه؟ What's the difference? Yes, mutagenicity, teratogenicity means a drug passes through the placental barrier to the baby and affects the formation of the baby. Mutagenicity means a drug affects the genetic makeup of a cell. It might be a somatic cell. It will harm that individual, and it might be a gamete. So it will harm the baby coming. Type. In mutagenicity, what's different in the advice you're giving to the patient between teratogenicity and mutagenicity? ايوه ها لا with teratogenicity you're concerned about the mother. With mutagenicity you can be concerned about the mother or the father. I'll tell you an example. While I was working in clinical research and we were doing, actually that was when I was working in clinical pharmacology, and a patient was being treated with a drug called ribavirin. Ribavirin for hepatitis. Ribavirin is mutagenic. He should and his wife exercise contraception for as long as the father is taking ribavirin and for 3 months after stopping ribavirin. Why? Because the spermatozoa, they remain in the epididymis for 3 months, up to 3 months until they come out. So here is contraception for both the mother and the father. Very good contraception. Yeah. ها؟ وفيتامين A. بس فيتامين A steratogenic كمان. Type E reaction, abstinence syndrome. Okay, these things become less important. Just read them, type E and F. Now, drug interactions, just the principle. No examples here. Just know what's a kinetic interaction, what's a dynamic interaction. If a drug kicks another from plasma proteins, effects will increase. Hepatic macrosomal enzyme inducers are going to decrease the effect of a drug that is metabolized into inactive form. Okay? أنا بقول الكلام ده ليه؟ بس ده مش هقوله لكم. This is too difficult for you. Sometimes the enzyme metabolizes the drug from a prodrug to the active drug. If you give an inhibitor, you're going to decrease activation. If you give an inducer, you're going to increase activation. But leave this aside. The simple fact that if you give an enzyme inducer, it will increase inactivation of any drug metabolized and inactivated by that enzyme. And the opposite, pharmaceutical drug interactions. Now, this is important, but you will know it next year. So don't memorize examples. All these interactions, it's about principles. That's it. Without examples. Without examples. Just that there is drug interactions, the competition for active tubular secretion. So this is تجميع, just changing pH. Just understand how this competitive, non-competitive antagonism again. So it's nothing really, these are not new. These are important, addition or summation, synergism. Type. I will tell you example here, but I don't expect you to memorize it. As an example of synergism, we have antibiotics that work in multiple ways. Some antibiotics will destroy the cell wall of bacteria, will destroy the bacterial cell wall, and some antibiotics will prevent protein synthesis inside the bacteria. So if you give one of them, it's going to be inhibitory, okay? But if you give both together, they will help each other because one is going to open the wall and the other one is going to get inside to perform protein inhibition. This is just to explain to you what synergism means. It's 1 + 1 equals more than 2. However, addition is simply an additive effect. Potentiation, I give a drug which doesn't have an effect. This example, again, example is not written, so just know, but I will tell you an example for you to understand. If I give you penicillin, it is secreted by the renal tubule. If I give you something else called probenecid, it will compete with penicillin for secretion. Is this going to increase or decrease penicillin in the urine? It's going to decrease penicillin in the urine. It's going to increase penicillin in plasma, so it will potentiate. Probenecid has no antibacterial action by itself. Okay? Reversal of action. This you will know it next year. Antagonism, opposing actions. Types of antagonism, chemical, physiological. You know this already. Dosing here. This half page is very important. Very important. This half page. What's the definition of a therapeutic dose? What's the definition of a loading dose? What's the definition of a maintenance dose? What's the minimum effective dose? Median lethal dose. Now, I need you to understand here the difference between the therapeutic index and the therapeutic window. The therapeutic index is when we divide the lethal dose 50 by the effective dose 50. What's the lethal dose 50? This is an animal experiment. This is a dose that kills 50% of the animals. Effective dose 50 is a dose that cures 50% of the animals. So the ratio, the higher the ratio, the safer or the less safe is the drug? The safer. The lower the ratio, the less safe is the drug. This is a measure of safety. However, this is used in the lab. In the clinical setting, doctor, and you have a patient in front of you, you don't talk about the therapeutic index. You talk about therapeutic window more. Okay? What is the therapeutic window? It is the difference between the minimum effective dose and the maximum tolerated dose. Because this is the window of doses that you can give, and you can give more and more and more effect to the patient. Remember when I told you about efficacy? Efficacy is the most important property of a drug. How far you can increase the dose and obtain effect without harming the patient. Okay? So know the difference between them. Okay, don't read these. Don't read this. We're left with the العملي. Now I'm going to flip some slides for you for the practical. Okay, I'm going to put this. I'm going to put this on the link. You will have it tonight. I know you already have something of it. It's been distributed last year. Okay, there are some additions, pictures, just photos, just extra photos, nothing extra in the words. Okay, so you need to be able to know the classification of the routes of administration, the difference between a route of administration and dosage form. What's a route of administration? It's the way you give the drug, orally, intravenously, intramuscular. What's a dosage form? It's the form of the drug. Ampoule, vial, tablet, capsule. اتفضل. I will send it. Okay, as you can see, parenteral dosage forms. You have these dosage forms. These are dosage forms. Dosage forms. Forms, not routes. Know the difference. Okay, these are all parenteral forms. You should be able to know the difference between the ampoule and the vial. What is this? This is a vial. What's the difference? Ampoule, you break it, you take from it, you throw it. Vial, it can be for multiple uses. And of course, it has precautions. Again, this is an ampoule, this is a vial. Okay, these are dosage forms. These are again ampoules. This is a vial, this is a bag, and this is a bottle. The difference is the bottle is well formed, the bag is deformable. These are all dosage forms for parenteral administration. So these are all photos. This is very important about the site of administration. These are the layers of the skin, and you should be able to recognize where the tip of the needle is going. Is it only intradermal? Is it in the subcutaneous tissue? Is it intramuscular? This is intradermal. How many uses do you know for intradermal? Vaccination and sensitivity tests. This is again intradermal. This is going where? Subcutaneously. And you should be able to know what is where the onset is delayed, that subcutaneous administration will be there if there is vasoconstriction, if there is shock, because the patient will have very low blood pressure. There will not be peripheral circulation. Cold application is going to slow down subcutaneous administration. Again, this is pointing to subcutaneous administration and the fact that you don't enter into the muscle. You should only grab a layer of the subcutaneous tissue, not the muscle. These are the sites for subcutaneous injection. This is what? This is subcutaneous pellet implantation. It is usually used for hormonal dosage forms or hormonal dosing, depot. I will ask an intelligent question. I need someone intelligent. What is the type of kinetics involved in this absorption? First or zero order? And explain your answer. ما هي absorption ده kinetics. ها. First order. ها. Why? Why do you think it's first? انت بتقول كده. تمام. ماشي. رأي يحترم. لحظة واحدة. أنا in a lecture فأخلص بعد شوية صغيرين وأتكلم. أوكي؟ ها. مين قال زيرو؟ قول ليه؟ ايه اللي يخلي دي زيرو؟ What makes it zero؟ ايه اللي يخليها fixed amount؟ The surface area of absorption. Let's say in this capsule or in this pellet, you have 10 milligrams of something. How am I going to absorb these 10 milligrams if it's very small and it's only this surface area which is available in contact with my body? So there is a fixed amount absorbed per unit time due to the limited surface area of contact with the body. So it's a zero order absorption. Another example of zero order absorption, iron. Because you have a limited carrier of iron for absorption. You can absorb only a limited amount per day. This is again zero order absorption. I want to consolidate this, that the word zero order just means a fixed amount per unit time. It doesn't mean only elimination or only excretion or only metabolism. It is just when you limit the process by fixed amount rather than a fixed what? Percentage. تمام؟ Okay? طيب. Again, this is about pellet implantation. This is going where? Intramuscular, and these are the factors that enhance intramuscular absorption. These are the sites for intramuscular. Okay, this is intravenous. Of course, intravenous is very rapid. Yes, it's very dangerous. Used in emergency situations. This is all. This is a cannula. This is a syringe. These are vials. What is this? What does it look like? Bottle. What does it contain? Is it clear or is it not clear? Is it a solution or is it a suspension? It's actually an emulsion of a lipid-soluble anesthetic that's called propofol, and it's given intravenously as an emulsion because they cannot give it in any other way. اتفضل. أي سؤال؟ الأنستيزيا. ما ده بروبوفول أنستيك، بس بقى إيه؟ هو lipid-soluble موجود emulsion. تمام؟ فهو ده شكله. فبس عشان تعرفوا إن sometimes need to infuse emulsions, or sometimes we can infuse emulsions in very few situations. طيب, intravenous injection, all about it is important. Intraarterial. When do you use intraarterial? Either you want to inject something radio opaque and you want to take a photo of the circulation, or you want to inject a drug which is very dangerous and toxic just in one organ. In fact, it would be very good idea if you can give the drug only to the organ it should go to. يا سلام لو اقدر ادي دواء القلب للقلب بس ودواء المخ للمخ بس. بس ساعات لما يبقى cytotoxic drug which is very toxic, sometimes we cannulate an artery and we give only the drug into that artery to that particular organ. So this is an application for intraarterial. This is intrathecal, and intrathecal we have a certain level to inject into. After the end of the spinal cord, there is a space with CSF. So this is where we give intrathecal. Okay, again. These are some exercises. I'm going to email you this. I'm going to put it on the link. Okay? All of this is going to be on the link for you. You can have a look at it. And I hope it will be helpful. Inshallah. Oh, by the way, these are the inhalation. This is what it's called what? This is what? This is a meter dose inhaler. What does it mean, a meter dose inhaler? Metered dose inhaler. Meter dose means that the dose is fixed. When you puff, you get 100 micrograms or you get 50 micrograms. This is what you get. It is measured. That's why we call it metered dose inhaler. It can have different forms. This is a metered dose inhaler. This is a dry powder inhaler, but I will not ask you that difficult, okay? Because this is the dry powder in a capsule and you inhale the dry powder. This is again a metered dose inhaler. This is a dry powder inhaler. Okay, that's it. I will try to get you everything. Thank you, thank you, thank you. I hope it was beneficial. Okay, first of all, we're going to stop recording. Okay, anyone who wants to ask something scientific, not what's important, what's not important now, can send me on WhatsApp, no problem. Okay. Yes. Yes.
هو حضرتك قلتي الفاكتورز affecting الاكشن والدوسج اوف drugs دي ما نقراهاش صح؟
Very well.